Good evening, and thank you all for joining us for this webinar, which is part of a series of presentations that are going to be delivered on alcohol and other drug use and funded by the Sydney North Primary Health Network. I'd like to begin by acknowledging the traditional custodians of the land and paying my respects to elders both past and present, and also extend that respect to other Aboriginal and Torres Strait Islanders who are here present today. My name is Christina Morell. I'm a Senior Research Fellow and Program Lead of Treatment and Translation among Complex Populations at the Matilda Centre for Research in Mental Health and Substance Use at the University of Sydney. I had the very great pleasure of co-facilitating this webinar tonight, along with Associate Professor Catherine Mills, and this webinar is going to be presented by Dr. Louise Birrell and Belinda Volkoff. Dr. Louise Birrell is a postdoctoral research fellow within the Matilda Centre at the University of Sydney. Dr. Birrell's research examines the links between alcohol use and mental health in adolescents. She has extensive experience trialling substance use and mental health prevention programs and conducting systematic reviews of substance use related mobile apps and app development. Dr. Birrell will commence an Australian Rotary Health funded postdoctoral fellowship in 2019 and will be developing a smartphone app for adolescents to support their friends with mental health and substance use problems. Belinda Volkoff is a clinical coordinator at the Sydney Drug Education and Counselling Centre, or SDEC. Belinda has over 20 years of experience working with young people with co-occurring substance use and mental health issues, as well as counselling parents of those young. Belinda was pivotal in the development of SDEC model of service delivery, which has state and national recognition. And she also sits on the network of Alcohol and Other Drug Agency Practice Leadership Group, and we're extremely lucky to have both Louise and Belinda here tonight. So just before we begin, I'd like to draw your attention to the Q&A and chat buttons on your screen. Please feel free to click on those and type in any comments or questions that you might have at any time during the talk tonight. We'll have time at the end of the presentation to go through any questions and comments that you send through. And if you experience any technical problems during the webinar, you can call the technical support line that's up there on the screen, or visit the Zoom support webpage and chat with an online staff member. We'll also be putting this information into the chat box so you can find it if you need to during the presentation. We're also recording the webinar, so if you'd like to view it again or download it, the slides as handouts, you can access them at the website on the screen. And lastly, if you're joining us for the live webinar tonight, please remember that you can complete the CPD assessment at the end of the webinar if you would like to claim CPD points against this activity. And now I'd like to hand over to Louise, and she's going to start by giving us some information about patterns and prevalence of substance use among young people. So thanks, Louise.
Thank you, Chris. So before I have a look at some of the data, I just wanted to go through the key learning outcomes from the webinar today. So I'll be covering patterns of substance use amongst young people and then handing over to our clinician Belinda to take you through how young people present to GPs and allied health professionals, understanding when a young person has readiness to change in relation to their alcohol and other drug use, and what's helpful in creating access to healthcare, particularly for young people. So to kick off, we're going to have a look at some prevalence data around the rates of drug and alcohol use amongst Australian young people. And to do this, I'll be looking at data primarily from two large nationally representative surveys. The first being the Australian Secondary Schools Alcohol and Other Drugs Survey, or ASAD, with the most recent being conducted in 2017 with approximately 20,000 young people aged between 12 and 17 years of age who are in secondary schooling. And the second survey is the National Drug Strategy Household Survey, which was most recently conducted in 2016 and surveys Australian households on their use of alcohol and other drugs, as well as their attitudes and opinions towards drug use in Australian society. And while these two general population surveys give us a really good picture and overview of the patterns of drug and alcohol use amongst young people in the Australian population, they do have some limitations, and it's important to point those out from the beginning. So firstly, the ASAD, or secondary school student data set, only surveys those young people attending formal schooling, so it misses those young people who've dropped out of school. And similarly, the National Drug Strategy Household Survey surveys private dwellings, so it misses certain populations such as homeless populations or people transitioning between houses and temporary accommodation. So these people are not represented in this data set. And it could be the case that these people might be more likely to be using alcohol and other drugs So the estimates I'll provide could be an underrepresentation of the actual rates of alcohol and other drug use. So just to keep that in mind as we go through. And I will be looking at data from other sources, including emergency presentations, and I've tried to pull some local level data specific to the Sydney North region, so have a look at that as well. But just to keep in mind that it is complex and it can be difficult collecting data on young people's drug and alcohol use. It's important to look at a range of sources so we can hear about this. But to kick off now, looking at the types of drugs most commonly used by young people in Australia. So by the age of 25 years, about 70% of Australian young people will have ever had a full serve of alcohol, 43% will have tried an illicit drug, 36% will have tried cannabis, and 25% will have ever smoked a cigarette. In relation to the past 12 months, 6% of 18 to 24-year-olds report using a prescription medication for non-medical purposes, with the most frequently used prescription medications being painkillers, analgesics and opioids, followed by tranquilizers or sleeping pills. So next I'm going to have a look at some of the data broken down firstly in 14 to 19-year-olds and then 20 to 25-year-olds. And that's because these are two different groups of young people. So if we think of 14 to 19-year-olds, the majority of these are still in school, often living with their parents or experiencing relatively high levels of supervision. And we see drug and alcohol use starts to take off in this period. But when thinking about 20 to 29-year-olds, this is a different phase in life when people are generally much more independent. They are maybe working, have their own personal income, not living with their parents as much, unless you're in Sydney, where you're living there for a long time until you can afford a house. But in general, they have much more independence, and this is when we typically see drug and alcohol use peak. So firstly, to look at 14 to 19-year-olds, this is from data from 2001 to 2016 from the National Drug Strategy Household Survey, and it's the percentage of 14 to 19-year-olds who report being engaged in alcohol or other drugs. And just to point out that the red line here is alcohol use in relation to monthly use, experiencing a single occasion harm in a month. So this is defined by the NHMRC guidelines of risky drinking, which is 4 or more standard drinks on a single occasion. This is the percentage of young people who report consuming more than 4 or more standard drinks on a single occasion. And in relation to smoking, this is where the young people report being daily smokers, so just to point that out with this data. But if we look in 2001, 39% of young people aged 14 to 19 years reported consuming more than 4 standard drinks on a single occasion, compared to just under 18% in 2016. In 2001, 28% reported that they consumed an illicit drug in the previous 12 months, compared to 16% in 2016. And in 2001, 5% reported being daily smokers, compared to 3% in 2016. Just looking now at illicit drug use amongst 14 to 19-year-olds and the most common types of illicit drugs that are used. So marijuana, cannabis is by far the most commonly used drug, followed by ecstasy, cocaine, and methamphetamine. We are seeing rates of use drop across this period, particularly in relation to marijuana and cannabis, while the others remained fairly stable. Now looking at the 20 to 29-year-olds, so we see overall higher rates of involvement with alcohol and other drugs in this age group. So in 2001, 50% of young people aged 20 to 29 reported consuming more than 4 standard drinks on a single occasion, and this dropped to 40% in 2016. 35% had consumed an illicit drug in the previous 12 months in 2001, compared to 28% in 2016. And 26% reported being daily smokers, compared to 15% in 2016. We see a fairly similar pattern in terms of illicit drug use, with the most commonly used illicit drug being marijuana and cannabis, followed by ecstasy, cocaine, and methamphetamines. So these graphs give us a picture of roughly the number of young people who are using alcohol and other drugs. but it doesn't tell us anything about the patterns of use, including frequency of use, the number of occasions people are using, or any information about those patterns. So we're next going to have a look at that for alcohol, tobacco, and illicit substances. So looking at patterns of alcohol use, we're seeing a general pattern in the general population that younger people are delaying taking up drinking. So the average age of first having a full serve of alcohol increased from about 14 and a half in 2001 to 16 years in 2016. However, we are still seeing a portion of young people consuming alcohol and consuming it at high levels. So people in their late teens and early 20s were more likely than any other age group to consume 11 or more standard drinks in a single occasion in the past 12 months in the Australian population. So about 1 in 14 had done so at least monthly. And we so know that there's still a group of young people who are drinking at very high levels, even though overall in the population more and more young people are choosing to abstain from alcohol. Looking at the Australian secondary school student data, we see similar patterns with more and more young people deciding to abstain from alcohol. In 2011, 74% of students reported they had ever drunk alcohol, and this decreased to 66% in 2017. And 15% of the students still reported that they had drunk alcohol in the past week, and we're seeing this rapidly increases with age, so much more 17-year-olds, for example, compared to 12-year-olds report drinking alcohol. And 5% still drank at risky levels in the past week when surveyed. When secondary students are drinking, we can see that about 9% of 16-year-olds have had 5 or more standard drinks in the past week when surveyed, and this jumps up to 13% of 17-year-olds. So as they're reaching 18, the involvement with alcohol rapidly increases as they're reaching the legal age, which we would expect. And the drink of choice for secondary students is pre-mixed spirits, followed by spirits and then beer. And 43%, so just under half of the secondary students, reported that parents were the source or main source of alcohol. Having a look at trends over time in this population, so this is the ASAD data from 1984 up to 2017, and looking at the rates of alcohol use and whether students have ever consumed or classified as current drinkers by the solid graph. And then the broken graph down the bottom there is whether young people were classified as risky drinking. So that's the higher levels of drinking on single occasions or binge drinking. So we can see that more and more young people are choosing not to drink alcohol, and that solid graph has shown a rapid decline over time as more young people abstaining generally from alcohol overall. However, the rates of risky drinking have remained relatively stable. So there's still a group of young people who, from 1984, were drinking at risky levels, and this has dropped off slightly, but there's still a substantial portion who are continuing to put themselves at risk of harm in the way they're using alcohol. And young people, we know young people are particularly vulnerable to short-term harms. They're more prone to make risky choices, especially under the influence of alcohol. Just over half of students who drank alcohol did report that they experienced at least one negative result from drinking alcohol, with the most recent listed, the most common negative events listed there. This is some data I've pulled that was broken down according to local health district. So this is the number of secondary school students aged 12 to 17 years who report that they've ever drank alcohol. So across all local health districts in New South Wales, 61% of secondary students reported they've ever drank alcohol. Looking at the Central Coast and Northern Sydney local health district in particular, 57%, 57.5% had ever drank alcohol. So this is not too far away from the state average, but slightly lower. We can, I guess, the thing to point out from this slide 2 is that we do see variation by region. So while the data presented to date in the slides is the national averages, it does average across regions. We do see slightly different rates and trends across different areas. Looking now at tobacco, so as of 2017, 82% of young people or secondary school students had never smoked a cigarette. So we've seen a real decline in young people taking up smoking in general. Also, 1 in 20 secondary students who were current smokers, 5% of those had smoked in the past week. And we see many more 17-year-olds compared to 12-year-olds. So the rates of smoking do increase as students get older, which you would expect. Most smokers obtained their cigarettes from friends or family, with about 18% buying them for themselves. Looking over time, so this is the number of secondary students who reported that they had smoked tobacco in the past month from 1984 to 2017. And we can see, similar to alcohol, overall these rates have really dropped off, with secondary students delaying taking up smoking and smoking on a regular basis. Looking at illicit drug trends, we did see in the National Drug Strategy Household Survey an increase amongst females in their 30s using illicit drugs in the most recent survey when compared to the previous survey. So in 2016, 16% of females in their 30s reported they had used an illicit drug, compared to 12% in 2013, with recent use of cannabis, ecstasy and cocaine increasing. However, in general, we have seen that the average age of illicit drug use has risen from 2001. So the average age in 2001 was 29, and that rose to 34 in 2016. But we do see that people in their 20s, that age group of 20 to 30, are the most likely across the whole of the Australian population to have used an illicit drug in the past 12 months. But generally, there was a decline when comparing the number of young people in their 20s who used an illicit drug from 2001, which was about 35%, dropped to 28% in 2016. And there's an interesting trend there around people in their 40s, which isn't focused on young people, but there was a slight increase amongst people in their 40s using illicit drugs. But nevertheless, these rates are still nearly half those in people in their 20s. So we see here that 16% of people in their 40s have tried an illicit drug in the past 12 months in 2016. That's still much lower than the 28% of people in their 20s who used an illicit drug in 2016 in the past 12 months. So in summary, the data from these large population surveys are showing a general decline in the use of alcohol and illicit drug use amongst young people in the general population. However, they're still the most likely age group to drink alcohol in risky quantities, use cannabis, ecstasy or cocaine in relation to the previous 12 months, and we compare it to any other age group in the Australian population. And while these types of surveys are really useful in giving us an overall picture of the prevalence rates and trends across time, they might not accurately represent some groups, so particularly young people not formally in education, homeless populations, as they tend to pool across national averages. And it also doesn't reflect certain spikes in particular communities. So it's important to acknowledge that, as we know that drug trends do change according to regions, and in certain communities can see certain spikes in use. And Belinda's going to talk to us a little bit about the trends she's seen soon. But before I hand over to Belinda, I'll just quickly touch on some of the treatment seeking data. So to date, the data I've had a look at so far has been the Australian general population. This shifts when we look at people who are actively presenting and seeking treatment for alcohol and other drug use. So looking now at those young people who present for treatment, we've tried to look at the most relevant data from New South Wales. Firstly, we'll look at the Australian average, and then we'll have a look at the Northern Sydney Primary Healthcare Network data. But in relation to young people under the age of 30, There are about 76,000 young people under the age of 30 presenting for treatment for alcohol or other drug use across Australia in 2016-17, and this represented about 40% of all clients. But a substantial portion of the clients presenting for treatment are young people. The most likely drug that they would present for treatment for was cannabis, followed by amphetamines. It was most common that young people would say that they referred themselves or a family member had referred them for treatment, followed by a health service or diversion program. And the most common type of treatment sought was counselling, followed by support and case management only, and assessment only. Looking now at the Northern Sydney Primary Healthcare Network, the graph circled here by the purple box is the number of young people presenting for treatment for alcohol and other drug issues amongst the Northern Sydney Primary Healthcare Network. And we can see that it's not an insubstantial portion, so just under 10% of all clients were aged 10 to 19, and just under 20% were aged 20 to 29. Unfortunately, I couldn't break down the other data according to age, but there's just a breakdown there across all clients in the Northern Sydney Primary Healthcare Network. So we see they're mostly male, mostly non-Indigenous, and they're seeking treatment for their own alcohol and other drug use rather than others. Before I hand over to Belinda, I just wanted to touch on some data we've seen from the methamphetamine-related emergency department presentations. There's been a lot of media attention and a lot of focus around crystal methamphetamine or the drug ice and the harm that it's causing in the Australian community. So I wanted to present this data. This is New South Wales data only, and it's the number of cases who presented to an emergency department because of a methamphetamine-related issue. This is all methamphetamines, not necessarily just crystal methamphetamine. It can also include speed and other forms of methamphetamines. But we did see a rapid rise from 2009, 2010, peaking around 2015 and 16 with cases presenting to emergency departments related to methamphetamine use. And young people were amongst the highest number of these. So the red line there is 25 to 34-year-olds, and the light blue lines, sorry, that purple box should spin down a bit further, the 16 to 24-year-olds. There was a trend of an increase in presentations to emergency departments related to methamphetamines, with young people being heavily represented in these presentations. It does look from this data that there was a peak around 2015, 16, and it drops off slightly after this. And while we can't comment further on what's happened since then, it would be interesting to hear particularly Belinda's views on what people are presenting for as it rapidly changes. So I'm now going to hand over to Belinda to take us through the rest of the presentation and share with us her clinical knowledge and expertise. Thank you, Belinda.
Thanks, Amy. Thank you, Louise, for your stats and for preempting me to turn that hopefully into something a little bit about what we see in terms of presentation. And I notice it's really important that Louise kind of did highlight, and as will I, it is very hard for us to get accurate statistics around absolute up-to-date trends because we just don't do those sorts of audits. To bring it back to something real and to share with you a little bit tonight, and hopefully it's helpful for you about how young people may present and what can be helpful in relation to working with young people. I'll just start with that by letting you know a little bit about our service very briefly, that we are a specialised service that does work with young people with problematic substance use. So generally we're not working with young people that may be in very early stages of experimentation, although if anyone ever has questions about that, we encourage people to have that discussion further with us. But normally young people that do present have some level of substance use that has now become problematic, and this is generally shown also in a co-occurring way. So I'm still yet to meet a person that is just a pure drug user and there's not a variety of potentially other factors going on for them. It's not necessarily illness, but most certainly mental health symptomology can come out during that time of adolescence. And we know that 50% of those things develop during that time. So it's understandable that we would see high levels of comorbid presentations. We work with basically young people between 12 to 25, just to ensure you that I am not flooded in our clinical rooms with 12-year-olds. We do know, we just dropped the age recently from 14, but that was only because we have parents accessing the service, and I'll talk to you a little bit about that. So the primary clients who work with the young people 12 to 25 with some form of substance use disorder, and then we do intensive support working with parents or guardians of those young people. Just to remind you of the area that we're in, our area at ESTEC covers the primary health network. We have offices located at St Leonard's and Manly. We also have a relationship with the headspaces of both Chatswood and Brookvale, and we have a variety of referral services, and we welcome GPs or allied health professionals to even investigate with us whether they think that a referral pathway may indeed be necessary. Reflecting on some of the stats that we're kind of seeing currently at ESTEC of how people present, generally in the community, I think most of us that are in the sector and in the health profession can be aware that we have this real focus around methamphetamine and ice, and most certainly our colleagues in rural areas are working more a little bit in the coalface of that. In saying that though, ice in methamphetamine is only one form of methamphetamine. In the northern Sydney region, we'll see amphetamines more come up in relation to caps, or people refer to as ecstasy. They're hoping for MDMA, but we also know that quite often there's amphetamine-based drugs in those drugs as well. Again, the most presenting drug for us as a service, particularly in the last even 10 years, has been cannabis as the most presenting drug for young people, primary drug of choice. And secondary to that, alcohol. 15, 20 years ago, we would see that the other way around. And then methamphetamine or amphetamines rather are kind of coming in at a third. Interestingly enough, before speaking with you all tonight, I just quickly did a retake, because we've seen these interesting trends coming through that I want to talk to you a little bit about around the abuse of pharmaceuticals. And we've just realised that benzos, in a snapshot, we're still forming this for our yearly report, but looks like benzos are actually equaling presentations to amphetamines as primary drugs of choice. We do actually collect data for secondary drugs, but often primary drugs are the ones that people focus on. So again, the overwhelming drug is cannabis, followed by alcohol, methamphetamine, as I said, benzos. I wanted to touch on the thing about some of the concerning current trends that we're seeing in relation to pharmaceutical abuse, mainly in the benzodiazepines. And interestingly enough, I think we all wondered what would happen when alprazolam or Xanax was made Schedule 8 many years ago. I feel like I'm seeing more of that now. We certainly know, and people are, where do they get it? Obviously diversion through prescriptions and those things happen. Online, I think, has brought in a new kind of area. People worry about the dark web. They focus a lot on the illicit substances of the dark web, but in my experience, I'm finding more people getting the licit or the illicit use of illicit substances through the dark web or other types of online ways. Diversion can come through, particularly around ADHD medication. We're seeing quite a large diversion around Ritalin and the dexamphetamine type drugs, and other psychiatric drugs, funny enough, that have come up in recent times, one being quetiapine. I do think that there's a lot more prescribing for that, and we know that there's more prescribing for that around anxiety. It's not uncommon that sometimes young people will be prescribed that in relation to withdrawal. And we try and avoid medicated withdrawals, sometimes depending on where the person's at. But again, that's a collaborative discussion that we can have with GPs. You are the GPs, you are the prescribers. We respect that, but we like to have conversations so that we're on the same page for the client. There has been increases in the abuse of modafinil and also pregabalin in the Lyrica. We saw a lot of that being used, again, diverted by young people in recent times. Just keeping that snapshot aside and moving towards, what's helpful. And I guess I put up this little kind of funny clip because very often, understandably, we're all in our very busy worlds with the same goal, and that is the health and wellbeing of our clients. However, we do specialise in different areas, and for GPs, particularly for those of you out there that are GPs, you're supposed to be good at absolutely everything, and that must be very stressful at times. One of the things that's very difficult and being time poor is this idea that people will ring up drug and alcohol services at times and say, look, you just need to make them stop. Again, look, and if I had a magic wand for that, I can guarantee you I'd be very wealthy. It is a complex thing, particularly with those comorbid presentations, but we don't work with just the drug in relation to that. We also don't look at making people quit. Adolescence is very much a time of don't tell me what to do. It's a sure recipe if they don't have any form of readiness for change, that you may get someone who will be very compliant and just say everything you want to hear so they can get out, or they'll actually get a bit annoyed and not being told what to do. So let's have a look at that kind of thing when people do present to GP services and indeed to our service. It is unusual that I would have a 15 or 16-year-old come into my room and wipe their brow and tell me that they're completely over their drug use. I think that's what people want to hear. People also are hoping that they'll come into the room and there'll be some way that we can either scare them or concern them about what they're doing. Most certainly we talk about the harms in terms of drug relation as do our other colleagues. However, we also know that drug use is complicated. For me, when people reach areas of dependence, I think it's a result of a perfect storm. I think we try and simplify it because we're trying to find a way to work with young people, particularly when they're at risk of harm. You'll also find that you'll have quite often maybe a paralleled process with some of your parents, and the parents will be looking to you to fix or force their child into some form of treatment. And indeed, we can feel that sense of urgency from parents sometimes in wanting to do something quite urgently because they feel that their child's life is at imminent risk. In all the years that I have worked at it, we do work with imminent risk. And if we are dealing with that, that's a classic case of we're going down safety planning and ambulances and police. It's when they're in those areas where they're not quite acutely problematic, but we can see things are going on and regular use is coming in, but they may not necessarily be applicable for acute services, particularly around mental health, because if they're drug using in any way, people are often like, well, it's the drugs and we can't tell what we're dealing with because they're using drugs. But we know that people that don't feel comfortable in their own skin are going to use maladaptive behaviours, drug use being one of them. So just to take you back, and I'm sorry if this is familiar to you in any way, but stages of change throughout my career just sticks and follows with me. It's just such a great space for me to remind myself when clients are speaking in a certain way, what that's actually telling me, because we do often have to try and read between the lines without too much assumption either. So to just revisit that, this was a very important model that was developed many years ago by Prochaska and Di Clemente, and it was used for cessation of smoking, but it's incredibly useful to pretty much a lot of areas of our own lives in the idea of when you're going to make changes about something. And this is when we talk about the importance of readiness for change. So when we look at something like pre-contemplative behaviour, this is the area here where people in pre-contemplation enter a stage of pre-contemplation. And let's think about it in relation to those ones that are currently using, maybe not hugely problematic, maybe so, but not wanting to make changes. And you'll hear language like, I'm all good, sweet, don't have a problem, mum and dad are freaking out, they're really conservative, I'm not doing that much. That language is basically saying to you, I'm not interested in making changes right now, despite what everybody is telling me. And so we then start looking at, and I know some of you may have been involved in some webinars around motivational interviewing, but when we treatment match where young people are at, we treatment match it, and this works with all ages, by the way, based on some of the language that they're telling us. But when they're in pre-contemplation, they are actually not interested in making changes. So what do we do with that? Well, in terms of our language, and I'll speak a little bit more about language in a minute, but pre-contemplation is basically saying, I'm resistant. And what we need to do is we need to roll with that resistance. Now, that doesn't mean you're being permissive. Yeah, that's great, keep smoking cones. We're not saying that. What it is that you're not arguing with them. Guaranteed, with young people, they're already arguing with the other people in their lives, and perhaps they may come to you because they could be drug seeking in their behaviour in terms of, I can't sleep. So they might say to you, oh no, I don't have a drug problem, but I'm not sleeping and I'm not doing this, and but their language will be resistant. And what we want to do is a helpful way for young people as well is to be curious with them. The natural thing is to jump in and if we know that there's drug use there, to kind of give the warning, advising, because we're concerned about their health. And it's very tempting to do that, particularly if you've got a parent in the room with you. And I encourage you, by the way, if you need to have this conversation, to try and have it alone with the young person to provide an opportunity for them to be able to disclose that they are indeed maybe using, but they're not sure about what they're doing. And then you can invite them very gently around, well, would you be okay if we had a little bit of a chat about what's happening with your alcohol use or your cannabis use? And again, if they don't want that and they're blocking us, there's not a lot we can do when people don't have readiness for change. But we can move into areas around harm reduction and start talking to them about safety and could we talk about you being safe. Now, again, if there's still that resistance, just asking them if you can even monitor symptoms for them. So you say you're not sleeping well. We know that cannabis is renowned for creating problems with sleep. They will tell you they need it for that. If they're fighting you on that, saying, no, but I need it for them, they're saying to you, I'm in a stage of pre-contemplation right now. That's what it's saying to us when we talk of it in that language. Contemplation is developing an awareness of the problem. So they're starting to, and this is when through this phase you can monitor symptomology with them around, even with liver function tests or any of those things that they might need. If they're very, very underweight and they're smoking cannabis, we get quite concerned. We're seeing a real presentation these days in very, very underweight young people smoking fairly high levels of cannabis. And what we can see with that is we know that there's a real concern around nausea and the fact that system actually does, the endocannabinoid system actually does work in the gut. So what used to give them the munchies now becomes the opposite problem, they're not eating. And I think we've got to be mindful there that can be really great for GPs here to kind of encourage around talking to them, even not just about the drug use, but the issues that come with it, the associated risks. You know, you're really, really underweight. Does that bother you? Now, the girls may not be bothered by that so much, although some boys do, but we're having the conversation around their nutrition. And also, if they are actually starving, very hard to do therapy with people that are actually in some form of starvation syndrome, which we see very much with eating disorders. Just moving around as well and looking at preparation. This is when the person is actually starting to say things in their language about, you know, it's kind of like, I still want to use, but it's just, I just need to be able to sleep better at night, or I just need to be able to not argue with my parents so much, or there can be all of those things, or my peers are giving me a hard time because I'm doing different things to them. That's when they're starting to say to you, I kind of think I'd like to maybe look at this. May not necessarily want you to have the service on speed dial, but are inviting you to have the conversation. Then when a person moves into action, and these are differently the important times of when action is about, like looking at their behaviour, asking them if they want referral, getting all those referral things that you've been wanting to do for the whole time in there, and referring them to appropriate services. Maintenance is a phase that people generally are maintaining their goals. Now, for some people, it may not be abstinence, it may be reduction. Even if we think, well, I don't think you can do that, actually people can surprise you. So again, working with the person's goal around their use is really important. Relapse, which is kind of, I don't overly love that word, is falling back into old patterns. I prefer the word lapse, which means learning. People move through this cycle many, many times before they potentially make changes. And that's a very common thing. One of the things we need to normalise is that lapse is normal. Because what happens is everyone puts this investment into the person, and then, oh my God, they've used, and everyone thinks we're back to square one. And that's actually not necessarily the case. What I really want to share with you, though, is that most treatment services have often focused on the areas from action, maintenance, and relapse. Now, they are about the areas of behaviour change, very important around managing substance use, but we cannot shift behaviour until we shift attitude. And attitude is the area when you're working with young people, you can guarantee that when they're presenting to you, unless they're a little bit older in their 20s, and sometimes I have 18-year-olds say, I'm done with all my drug use. Not all the time, but people do if they've had experiences when they're younger. But usually they're still in that stages and they can stay there for quite a while. And when they're in those stages and we're not working around attitude or thinking about shifting attitude and focusing on the behavioural aspects, we can lose opportunity to continue that therapeutic alliance where we may be able to have some influences, even if it's reducing harm. The interesting thing is the family will be going through quite a parallel process at the same time. I certainly work with young people in out-of-home care, but I certainly work with a lot of young people that live in homes where their parents are very concerned about them, and they will have the same type of issues. So sometimes we need parents to have a look at this stuff a little bit differently, and that's why we work intensively with parents, and we found that when we do that, we have a 70% uptake of young people presenting for treatment when we can help the parents understand some of this language stuff and some of the barriers of what creates a young person's trajectory to go in the opposite direction. Parents are certainly not causal, but they are a very unutilised resource that we can tap into and encourage, and our service specifically works in that area. The other thing I just want to say about that is one of the biggest barriers, and in terms of pre-contemplation, is this idea around stigma that we all talk about. Now, many of you are very aware that we've come a long way, but still really coming a long way in relation to stigmatisation of mental health. Most certainly drug and alcohol is probably 20 years behind that. There is no doubt. The drug and alcohol sector itself was actually almost built on a process of morality as opposed to treatment and mental health and the separation. Everyone talks about why is it separated. We're still talking about that. There are many of us that are working with co-occurring areas, but still we're still constantly looking at how we can do that better. For us, we will co-treat those issues at the same time by accessing our own psychiatrist. It's only accessible via our service, by the way. I know they're very hard to get hold of sometimes, but we will work with that slowly. One of the things I thought could be very, very helpful for you, and this is a sector I can tell you, even as a drug and alcohol person that's been in the sector for over 20 years, I'm still grappling with. I mean, I really want to normalise how changing our language like we had to with mental health. So you're not a person with schizophrenia, you're a person that lives with psychotic illness. The change in our language can actually help people move through that attitudinal stages of change. So, I put this slide up for you because it's kind of, for me, it's rather appalling. But there is a dehumanising quality unknowingly that we can do when we talk about drugs with people. When families come into our service, they're almost hiding in the gate because of the constant levels of shame. Parents will measure their worth based on their children's behaviour. Only the child that's not functioning well, by the way, not potentially the other children that may not be indeed engaging in substance use for whatever reason. And we try and help families understand that, that this is really complex and it is a perfect storm, and there's no way they're causal, but we want to encourage them to be encouraging with their young person around their language. So again, this stigmatisation was something that I wanted to mention to you, but how do we deal with that? We will show you a slide at the end of really excellent resources for you. There is actually a lot of resources out there, we all know that, but it's finding the right ones. As Christina said in the beginning, I sit on the NADA Practice Leadership Group with an incredible bunch of clinicians, and NADA has produced this wonderful poster thing that I've got here, that the whole thing's not there, but you can get that off the NADA website. And this is a really, really important area that we can look at, trying to encourage change, just in a simple way we use language. So and look, by the way, some young people love the idea of calling themselves a stoner if they're wearing it as a badge of honour, but not always. And in fact, most people, I'll have young people come in and say to me, well, I'm just an addict. And I'm like, wow, you know, and say their name's John. I think you're John, and you're John that's using substances at the moment. And it's quite fascinating how they'll almost take that step back. The first thing they get shocked about when they come to a service like us, and I think this is really easy for anyone to do without the clinical work, is just to kind of roll with their resistance and say, well, how's this working for you? And they might go, great, having a great time. Okay. And then, you know, is there anything about that? Could we look at ways of keeping you safer? Or could we, so we go back down that road. In relation to language, thinking about words like, even when they're in maintenance, for example, and they might come into you and say, look, I had a really big weekend. I kind of, you know, you use, and you know, oh, you're busted. That's a common thing that people say, oh, you're off the wagon, or you're, or you've relapsed. You know, and people that unknowingly can contribute to shame. It's not our intentions. It's never our intentions. But language is a really important part to access and equity for young people. So and older people, actually. When people say to me, do you work with junkies? I usually say, do you mean somebody's child? It's actually about a person that's injecting drugs. So, for example, words like clean time. Have you got any clean time up? Which implies the person's dirty when they're not using, are kind of these really simple barriers. And I very much encourage you to have a look at that language matters thing. And again, I love this with young people. If you don't like my attitude, quit talking to me. You know, for me as a clinician, cultivating tolerance, and for you as workers, is something that we always must do. And for us to not personalise it, if we can't talk them into it, that there's something wrong with them, and we really can go down that road of over pathologising, which can also be an access barrier for people. Just a very quick case study for you before we go back for questions and those anything else that we're finishing up with today. Just a quick case study. This is quite an usual case we get here. Tate, 16 years old. Parents absolutely make contact first. Parents will ring up, very distressed, very vigilant. I don't mind. If that were me, I would feel exactly the same. I get that. What we don't do is match that vigilance. So providing steadiness, role models steadiness to the parent, which role models steadiness for them to use with their child. And often it's like when people talk about methamphetamine at the moment and they scream at me almost of, what do you think of the ice epidemic? I'm tempted to say, what answer will make you feel calm right now? It's really, really important that we're mindful that we can almost match that. Tate is someone whose parents made contact, came into the service, a big history about mental health service providers, a variety of diagnoses, and I'm sure some of you can relate to this, where you just almost confused yourself because he was exhibiting different versions of symptomology that was sometimes indicative of withdrawal or indicative of intoxication or indicative of indeed some of the mental health symptomologies that were being exacerbated. Definitely met criteria for cannabis dependence, but also did some alcohol mixing and benzos. DAS-21 score, extremely high in all areas, presented very unweight and not wanting treatment. So involuntary person, you feel like you have a hostage in the room. It's an awful thing. So then trying to kind of make them think, I'm sorry that you know, I know your parents are worried, trying to create some form of therapeutic alliance, and just even exploring with them in the early days, you know, is there anything about what you're doing that we could still keep you well and healthy? And even if they say, I just want to be well and healthy so I can use drugs, that will do. We will take anything if they're open to having discussions around managing their health. When we focus on things like if they're not going to work, we don't need to say we're not going to work because of that. We can easily say, how is that impacting on your life? They will actually tell you themselves. And then we can hone in on what is the things that they're actually ready to make changes of. With Tate, it was actually a really great experience we had with the GP and the underweight stuff. And we went around the weight stuff so that the GP was talking to them about having up and goes in the morning, maybe talking to a nutritionist, despite the fact that we were open about the cannabis use, while we were working with readiness for change and tackling that ambivalence and helping them develop some autonomy to be in control of their treatment. So the GP and our service worked very collectively, and we got to get them to reduce the cannabis use quite significantly. We got to reassess around the psychiatric symptomology and found that the ADHD wasn't prevalent, which doesn't always happen because we absolutely get that representation. But we were actually seeing some PTSD and some levels of anxiety. But again, great working relationship with the GP. And then once we'd done the psychiatric evaluation, the GP then could monitor and use the prescribed medication with that patient. Just a very quick note before I finish around, you know, abstinence may come at some point. I always say to parents and to other people, it will never happen fast enough for you. Know that the most important thing is that we always try and keep our patients and clients alive, because that's what we need to make sure we continue working. And opportunities for a positive experience, a rich therapeutic alliance, is an exception enough for when that person does indeed come back to the revolving door. With that note, I'd like to pass back to Christina. Thank you. Right. Okay.
You back on there, Chris? Are you muted?
I'm here, sorry, having some computer problems. Okay.
Thank you.
All right, so thank you so much, Belinda and Louise. I'm just going to, okay. So we've got some resources from both Louise and Belinda, which is really great, and they'll be available in the handouts as well for you. Louise, did you want to just mention these briefly?
Yeah, sure. Thank you, Chris. So I've just included a couple of resources in addition to Belinda's resources here that I'll quickly touch on. So Dovetail are a Queensland organisation, but they have some fantastic online webinars and resources that would be helpful to check out if you're interested just in understanding different drugs and population trends. They have a few on that, particularly in young people too. Your Room has fact sheets and guides, so A to Z guides on different drugs and services specific to New South Wales. And the Positive Choices portal is a portal for school communities, for parents, students and teachers, with a whole suite of resources around alcohol and other drug prevention resources that's worth checking out there. And I've just put in the links to the 2 surveys that I mentioned if anyone wanted to look at anything in further detail.
Great.
Thanks, Chris.
Thank you. So thank you again, Belinda and Louise. I know that I've certainly learned a lot. We've also had quite a few questions coming through while you've both been speaking. So this first one is for both of you. While there's been an overall decline in substance use, the rates of risky use remain quite consistent. Do either of you have any thoughts about what contributing factors might be towards this?
That's a fantastic question.
Yeah.
Louise, did you have something to say?
No, you go ahead, Belinda. I can add.
I was just thinking that is a really good question. And when we look at drug trends generally, and you look at them historically, you always see that up and down issue come in. It's interesting when we're seeing the stats go down with alcohol, but then we can see some little increases come up in other areas. And I think we've still done a great job. Like even with tobacco, we can see really great jobs of that coming down, but then that's now becoming a gateway via cannabis. So that's another thing that we're seeing. In relation to why, look, there's a really big sociological discussion to be had here on some of the reasons why we're seeing some of the change in trends. Is there anything more specific that we could maybe answer with that? Or Christina, is there a way, is that question, can that be reworded in a way that might be helpful? Or
not that I
can jump in, Chris.
Please.
I'm going to add to what Belinda said and say that in relation to alcohol specifically and that trend that we saw there of the declining use, there has been some work by Michael Livingston having a look at what could be driving that. And the cultural factors, as Belinda mentioned. We know that the choice of young people to use alcohol and other drugs is complex and determined by many social determinants of health. But in relation to alcohol specifically, we have seen a cultural shift in Australian society in general in the way they view alcohol. And it's been reflected in that National Drug Strategy Household Survey, with more and more people reporting that they see alcohol as the most harmful drug in Australia, which didn't used to be the attitude. So there's some hypotheses around that shifting attitudes, acknowledging the harm that alcohol does cause in some people's lives in Australia, a shifting cultural makeup of our society. So more and more we're seeing a shifting cultural mix of cultures where alcohol isn't acceptable, and parents who supply alcohol to their children. Parental control and approval around alcohol has become much tighter. There's also some thoughts around leisure time, and the way young people spend their leisure time now has shifted, particularly with the rise of online technologies, and they're much more likely to be supervised or in their bedrooms on their phones or playing games, compared to in the past where they might have been more sort of out, free range, so to speak, and unsupervised and having more access to alcohol. So some of those factors, I think, have led to this shift in the declining use of alcohol. But that doesn't answer the question, which was, what about that group who are still using alcohol at high levels? I think we don't really know yet. We can hypothesize that there might be a group who are less supervised, who might not be in formal schooling, for example, who might not have parents in their lives to monitor their use of alcohol and other drugs. We know mental health factors are related to use of alcohol and other drugs, so whether this group have higher rates of mental health difficulties. It's a really interesting question, and a lot of elements and more research that we need to do to really understand it.
And I think it's something we could definitely keep talking about, but just in the interest of time, I'm just going to move us on to the next question, if that's okay. Belinda, you mentioned that there were high rates of co-occurring mental health conditions. What symptoms do you typically see at SDEC, and do they tend to differ based on types of substances used?
Oh, great questions. I wish it was that easy to go, this one looks like this and they use this drug. Again, our need to simplify the perfect storm. What we definitely see, I mean, we've talked a lot about depression over the years, and there's been a lot more awareness raised, although I still, when people use the word depression, I do ask them, do you know what has that been in your version? Because misconceptions around mental health, I think. We see high levels of anxiety, there's no doubt. Obviously, we do absolutely see young people that are having either drug-induced psychosis or potentially in that prodromal phase of developing illness. So we see a variety of symptomologies from ADHD, PTSD. Obviously, trauma is another big issue. in saying that. But in saying that as well, even though we know that people with trauma-related symptomology, PTSD and those things are more likely to use drugs, in the Northern Sydney region we're seeing another area where we're seeing a lot of young people that almost have chronic levels of learned helplessness and not necessarily, so their symptomology is quite different, and there's almost a new cohort of client that we're actually seeing come through where they're not hanging their drug dependence or issues on tangible trauma, and they're even less likely to access treatment because they're not worthy of it. But what we do find when we're working with them is actually there's anxiety, there's actually some learned helplessness, there's a lot of buffering that's happening around them in not learning to be more resilient, really their well-being. And we're seeing quite a huge shift in the type of client that would have presented 15 years ago to some of the cohorts we're seeing now. And I think all of those factors contribute to what we're seeing.
Thank you. Okay. I'm aware that we are just running out of time, but I'm just going to slip in one last cheeky question, and then if anybody else has any other questions and we haven't answered yours, please email them and we'll pass them on to Belinda and Louise to answer and get back to you, if that's okay with you too. The last question I'm just going to ask about SDEC. You were talking about SDEC and the types of people that you're seeing, but what other types of alcohol and other drug services are available in in your area? And do you see people coming to you that live outside the PHN? And what
that is a really good question. And how I'll answer that is, firstly, we are very aware that SDEC has been we've only expanded up to 10 clinicians in recent times with the second site. We know the need is there. We also know out there that there's very little services that are available. So you will find youth services or mental health services, plenty of services are available for young people. Headspace is still one of the best places for people to start because most of us are on Headspace consortiums, and therefore they do those direct referral pathways. In terms of treatment for young people, very little. Detox and rehab, almost non-existent out of area. Again, it's not for everybody though. So anyone that wants to ask us questions, we don't take people from outside the PHN area, unfortunately. There are other services, and that's where ADIS and those places are bringing up for referrals are important. If you're inside our PHN, I can recommend. Outside of that, not so much.
Okay. Great, thank you so much. So I would just like to finish up by thanking you both again and let everybody know that we'll be making the video recording and handouts of these slides available tomorrow morning at the link on the screen there. Just look for the heading Workforce Training. As I mentioned earlier, if you are attending the live webinar, you can claim CPD points for this activity by completing the assessment through that link there on screen. And finally, the next webinar in this series will be held on Wednesday night, the 11th of September at 7:30 p.m, and that will be on alcohol use and pregnancy. You can click on the link on this slide to register as well. You won't be able to click on the live webinar, but when they're made into handouts, you'll be able to click them then. And again, thank you for joining us tonight. Thank you so much again to Louise and Belinda. I hope you all enjoy the rest of your evenings.
Thank you.
Thank you all.
Thank you.
Thank you.